Thanks. My name is Elizabeth Wilson. I'm a professor in environmental studies and director of the Arthur L. Irving Institute for Energy and Society. And today, I'm really excited to welcome Dr. and Professor Laura Paulin, who's a physician scientist and a practicing adult pulmonary and critical care specialist. And her research on environmental exposures, including occupational exposures and air pollution, feels particularly salient right now. While a lot of her research is focused on indoor air pollution, including particulates and some research in New Hampshire, I'm sure she'll talk about, it examines how our indoor air sources and home behaviors influence with our health outcomes and exposures. One of the reasons why it's so exciting to have her at Dartmouth, in addition to her having an NIH Career Development Award, her research really touches in and links rural air quality and rural indoor air quality in ways that no other research is touching. So Laura, thank you so much for being part of this talk. We really look forward to the conversation. And I'd like to ask people when the speaker is speaking to mute yourself and possibly also turn off your cameras just to save some bandwidth. We'll be having questions. You can send them to the Irving Institute, email in the chat box, and then I'll be reading them at the end of the talk. Thank you everybody for being part of this conversation today.
Thank you, Elizabeth, for the kind introduction, and thank you for inviting me to speak during this lunchtime lecture series. I'm going to share my screen now, so hopefully you'll see my slides without any difficulty, but please definitely speak up if there's any technical issues. So as Elizabeth mentioned, I'm a physician, pulmonary critical care doctor, and but I got involved in studying environmental health before I went to medical school. I initially thought that the path I was going to go was going to be looking at environmental policy. And then when I went to college, I became exposed more to kind of the public health side of things and realized that kind of tying my love for environmental issues with health outcomes may be a way to generate change on a bigger scale. And I ended up studying public health and environmental health both as an undergrad and graduate student at Johns Hopkins, and got involved in studying air pollution exposures in particular. Then started working with a group of physicians and biostatisticians and exposure scientists looking at the health effect of multiple pollutant exposures in urban Baltimore, and how that, in particular, minority and disadvantaged groups were disproportionately affected by these exposures. And then following medical school and residency, I ended up going back to Johns Hopkins to continue my training as a fellow in pulmonary and critical care, and worked with the same group I had worked with before, and really developed an interest in kind of indoor exposures and kind of the interface of household behaviors and socio-demographic factors and how that impacts our exposures. So I came here about 2 years ago from Hopkins, and will present to you some work from both places, but overall, in general, this talk is meant to be kind of an overview of what we do know about air pollution from the epi side of things. And I'm trying to click forward, but it's not working. There we go. So I don't have any disclosures, and as I mentioned before, we're going to give a bit of an overview of what we know about physical properties and chemical properties of air pollution, and focus really on the epidemiology studies that have come out of many decades of research in air pollution. And I just want to add that there is a whole body of literature that looks at tox studies and controlled exposure chamber studies, and we're not going to be looking at that right now, but all that information and data does exist out there, and those help inform these guidelines that I'm going to be speaking about as well. And just a general overview of what we will approach today. I'll spend a little bit of time at the end speaking about rural exposures given our location here in the Upper Valley. So this is a picture here, and normally in a lecture I would ask kind of what this may be, but for the purposes of this Zoom talk, this is a picture of London in the Great London Smog. And this is actually in the middle of the day. And there was such a thick layer of smog in the air that people had to turn on their the headlights when they're driving. Street lights were on, and all the signs in the shops in the theater district were illuminated. And you can see here that even during this time that this smog descended upon the city of London, people realized that it was probably not a good idea to breathe all this stuff in. So you can see people were doing kind of makeshift bandanas and face masks to try to avoid exposure. But it wasn't until later on, when people looked back, that people realized that this smog was associated with an increase in weekly numbers of predicted deaths. And this is an old slide, but kind of shows nicely what we're seeing here with that peak of weekly numbers of deaths associated with that fog in 1952. Later on that year, there was an influenza season that was pretty bad that also led to increases of deaths, but that did not match this peak that we saw with the London smog. The thinner gray line below shows the weeks, the same weeks in the year before, and you can see that there was some variability in deaths, probably related to that year's flu season, but again, this was not to the extent that you see with this high peak. And this was seen relatively close to the time that this fog happened. And this kind of prompted, this is one example of many of these kind of natural experiments that showed an association between these big exposures and increasing mortality. And this is just a kind of a summary of how these landmark studies and natural experiments on the left resulted in policy change, which I think is a really interesting study in itself, is how kind of these events lead people to make changes. In the case of the UK, this London smog was in 1952, and by 1956 they had passed the UK Clean Air Act, which is actually a pretty rapid turnaround. This wasn't certainly the first event that occurred, so there was some talk about making these regulations even before the London smog, but this really showed that this type of event really invigorated change in that city, in that country. And kind of going down the 1960s and 70s, we saw a big change in the United States, and increasing number of pollutants were added at different various levels of regulation, and we'll get into that a bit more as we go on. So in general, just a brief background on how air pollution is regulated in the United States. We have the National Ambient Air Quality Standards, which are required under the Clean Air Act, which was passed in the 1970s. And in the US, we regulate 6 criteria air pollutants in the outdoor air, and those are listed there. And I highlighted particulate matter, ozone, and nitrogen dioxide. Those are the type of pollutants that I tend to focus on mostly in my own research, and have a big track record of causing many human health impacts, and are still relevant today. So we'll focus on those moving forward. In terms of particulate matter, basically what we do is we regulate this by the size of the particulate matter. 2.5 and 10 are what you see in the Clean Air Act, and that's microns in aerodynamic diameter. And it's very, very small, as you can see here. And outdoor sources of particulate matter include traffic, power plants, atmospheric dust, which occurs naturally. And then indoor sources include PM coming from outside and going inside, and then cooking, fireplaces, and smoking as kind of own indoor sources, which are important kind of when we talk about heating and cooking in people's homes. The size of the particulate matter does make a difference in terms of where it ends up in your body and how it may impact your health. So our nasal passage, our upper airway, is designed to kind of trap larger particles based on the shape of our nose and the turbinates and airflow. So basically, if you breathe through your nose, kind of larger particles are going to be trapped in the upper airway by mucus and in sinuses and nasal passages, and smaller particles are going to continue to go down to lower parts of the airway, upper airway, and then the smallest particles are going to be able to get down into the alveoli, which is where the gas exchange happens in our body. And those small particles can be incorporated into the systemic circulation and cause a lot of inflammatory responses that lead to systemic disease. So this is just a very brief picture here that kind of demonstrates what PM can do from in the environment. It can lead to kind of this haze and the smog that settles over the city, and you don't really get the definition of these buildings. You can see the difference in the PM concentration here. So, you know, people did know about particulate matter for several years, but we weren't quite sure what it did in terms of human health in the United States. And this was a landmark study called the 6 Cities Studies that came out in the New England Journal in 1993. And the benefit of this study was it followed people over a period of around 15 years and looked at their ambient exposure to air pollution and all-cause mortality in 6 US cities. And what you can see here is that this is just a very basic, they had a lot of different study outcomes, and the 6 city studies are still being evaluated as this cohort ages, and people have looked at different analyses, but this is kind of the send home point of the initial study that showed in cities that had higher pollution, their probability of survival was lowest over the whole amount of time. So Steubenville, Ohio, and St. Louis had the highest concentration of PM air pollution, and their probability of survival over the course of the follow-up was less. And this was really one of the first studies, or the first study in the US that showed an association with PM exposure and mortality over time. And this has been shown in many more studies. And this is just a conglomerate. This is 10 years old now, so you can see that for all-cause mortality, for pulmonary disease and cardiovascular disease, there's been many, many studies here that replicate the findings of the 6 city study. And this is all for mortality. We also know that not only do long-term PM exposures make a difference, but short-term exposures on a day-to-day basis can be associated with increased mortality. This paper also from John Samet about 20 years ago now, showing that kind of day-to-day PM exposure can lead to increases in both cardiovascular and respiratory deaths, even when accounting for other pollutants. So this really is pinning down particulate matter as the kind of the main exposure of concern for these analyses. This study is also looking again at a conglomerate of daily and short-term exposures of PM and mortality. So again, not only those long-term exposures, but kind of shorter day-to-day exposures and short-term outcomes of deaths in the US and in European countries. So another example is kind of, you know, we know this body of literature supporting mortality, but what do we know about other outcomes? Obviously, when you're thinking about looking at epidemiological research, mortality is obviously a super important outcome, but you know, that's almost the end of the road. Like when someone's dead, you can't really get it back. Are there any things that we can learn from an epi standpoint that kind of backs up the outcome to something other than death, like important clinical outcomes, patient-reported outcomes? Those are all things that we want to know so that we can potentially, obviously, prevent this increased mortality by finding out what happens earlier in the disease process. So this is just a very small, kind of nice example of a natural experiment in asthma. So this was done in London, and they recruited people, 60 adults with mild or moderate asthma, and had them take a walk around the city for 2 hours in Hyde Park, where the PM concentration was quite low, or on Oxford Street, where it was higher. And they basically did a real-time assessment of exposures and outcomes. And they found here that in participants with mild asthma, the people who walked on Hyde Park had somewhat of a decrease in their FEV1, which is lung function, the forced expiratory volume in one second, but this was less than the decrease in FEV1 that was seen in the people who walked around on Oxford Street. And then when they kind of did a subgroup, they looked at the people who had more severe asthma, and they found that that decrease in FEV1 from baseline was even greater. And you can see that these were persistent over the course of several hours, and then basically almost 24 hours after the study started, they still had a decrement in their FEV1. We also did some biomarker assessment that showed that even during the short-term 2-hour exposure, people were having inflammatory markers increase following these PM exposures. Other outcomes that we tend to care about, obviously we do care about drop in lung function. Looking at emergency department visits is another thing that people like to do from an epi standpoint, because these data are often publicly available, they're in large data sets, and you can analyze things across many, many different cities or areas. This was one looking over the course of Atlanta over the course of 10 years, and looked at emergency department visits for asthma or wheeze, and focused on children, and saw that with the increase in PM concentration, there was an increase in the risk of these hospital visits for kids. So this is showing that even in children, we're seeing health effects with PM. And this is another nice study that is actually looking at things a little bit differently. All of the ones that I've shown so far is, what happens when you have an increase in PM, and what's the outcome? This is actually looking at things flipped. They said, hey, you know what? We've actually done a pretty good job in California with decreasing concentration of PM over several decades. What do we know now about these decreasing concentrations? Is that associated with improvements in health of children from a respiratory standpoint? And this did look at Southern California and looked over a series of decades, and you can see the general trend of the PM concentration over those decades have decreased, and the cities that decreased more had a bigger percent decrease in symptoms of bronchitis for the kids that were in this study. And on the bottom right-hand corner, the upper left of the chart there, you can see those cities had less of a decrease in particulate matter and a relatively flat change in the symptoms over time. So again, another kind of natural experiment showing that decreases in PM can actually improve some of these outcomes that we've seen before. And again, this is just a bigger picture. We did see that trend in decrease of PM in California. Overall in the United States, we've done a pretty decent job about decreasing PM concentrations over the past 2 decades. And you can see this trend that over probably about the past 10 years, we're seeing most cities in compliance with these PM 2.5 air quality standards, with a nice almost 40% decrease in the national average. And you can see at the bottom, this is based on kind of local EPA monitoring sites that are all over the country. And at the end of the talk, I'll point out why this may not necessarily represent what we're seeing in rural regions, but overall the trend is down, which is good. And that has been born of the Clean Air Act. We do review these standards every 5 years. This is kind of up for debate in the current legislature, that we might not actually be reviewing these standards every 5 years, as we have been for many, many decades. So this is a little bit at risk, and there is some concern that we're not going to see these nice trends down. But you can see here, this is not meant to kind of read the fine print, but you can see kind of the initial 1970s version of the Clean Air Act for PM, and as every couple years there's a reiteration, and the standards are tightened as they have more data from epi studies, from chamber exposure studies, from lab studies, from tox studies, and the concentrations have become lower and lower that we are seeing now. And the goal of the Clean Air Act and these national ambient air quality standards is to protect the most vulnerable members of our society. So we tend to see in this type of research that there's really no threshold where there's a safe level of exposure. And so, you know, it would be probably impossible to get these concentrations down to 0. So there has to be somewhat of a limit, but research has shown that it's kind of across the continuum on a linear basis. And this is the most recent iteration of the National Ambient Air Quality Standards. And this is readily available on the EPA website. So ozone is another pollutant that has been shown to be associated with many adverse human health effects. And what's interesting about ozone is that it is the result of a chemical reaction that involves nitrogen oxide species, VOCs, heat, and sunlight. There's good ozone that happens up in the stratosphere, and then there's kind of atmospheric ozone, which is the man-made pollutant in the lower atmosphere. That's the one we're worried about. And a whole host of studies have its own association between ozone exposure and mortality. Unlike the PM concentration that has decreased nicely over the last couple of decades, you can see that ozone has remained relatively flat over several years. You haven't really seen those nice decreases that we did before. And this has kind of led to a bit of a resurgence of interest in ozone as a potential exposure of interest. Since we've done so well on PM decreasing, we're still seeing, issues with air pollution, and people have kind of looked at a finer lens on ozone. This is a essay that came out last year from John Baums, who's a big exposure environmental scientist physician out at UCSF, kind of summarizing the most recent data on ozone. And this was a paper that came out recently from the MESA air cohort, which is multi-ethnic study of atherosclerosis that over samples minority populations to look at kind of trends in heart disease, and they also had an air pollution component. They found that higher air pollution in this study was associated with greater amounts of emphysema seen on CT scan in these participants, and this was kind of adjusted for all sorts of other exposures like smoking that could be associated with emphysema, and these are people who don't necessarily have any lung disease at all. So that was a bit of a surprise that despite kind of accounting for smoking and not having lung disease, that people were found to have increasing amounts of emphysema, largely due to these air pollution exposures. A study that I work with very closely called the Spiromics cohort, which is a disease-specific cohort for people with and at risk of COPD, followed people all over our country, has shown some interesting findings as well with air pollution exposures and COPD outcomes. And just a side note about why I care about COPD, as a lung doctor, it's one of the most common diseases that we see in our clinic and a major leading cause of death in the United States and worldwide. When we think of COPD, I think a lot of people think of smoking, which, definitely makes sense. It's the predominant risk factor, but I don't think cigarettes are the only thing to blame here. We know that about 25% of people with COPD have never smoked, and we know that some people who smoke 3 packs a day don't get COPD. So there are other kind of environmental and genetic factors at play. But when you think about what cigarettes are, they're basically noxious gases and particles, which is what air pollution is too. So it does make sense that there's some relationship between air pollution exposure and COPD development or worsening of existing disease. So in this study that we recently published, we looked at long-term exposure to outdoor ozone concentrations and kind of respiratory morbidity in this Spiromics cohort. And we found here that pretty much across the board of all of this one benefit of the Spiromics cohort is that people come in for these study visits and they have extensive clinical phenotyping and biomarkers and CT scans and blood tests and all sorts of clinical outcomes. And pretty much across the board, we found that higher concentrations of ozone in the last 10 years, averaged over a period of time, were associated with worse clinical outcomes, even when we're accounting for smoking, pack years, all other things that can be associated with these outcomes. We found that ozone signal was quite strong throughout our analysis. And in the last 2 rows, looking at exacerbations, which are very, very much of interest in COPD because they lead to increased healthcare costs and worse morbidity, there was a very high signal supporting the association between higher ozone exposure and more frequent exacerbations. So obviously we do care about outdoor air, and we know a lot about it, and the National Ambient Air Quality Standards obviously do a decent job of kind of regulating outdoor air exposures. But we know that Americans, and kind of older Americans in particular, spend most of their time indoors, and most of that time is in their house. And this is actually even more so in people who have chronic diseases like COPD or heart disease, or mobility issues, where even more of that time is spent indoors. So we really need to be focusing on the indoor environment as a big contributor to people's overall exposures, especially given the fact, and this kind of goes without saying, but it's just nice to remind people that, you know, there's really no way that we can regulate people's homes for air quality. I mean, there are building standards and codes, but in general, once you have your home, you kind of do what you will in your house, and no one's really coming by and regulating your air. And I think when we tend to think about air pollution inside, we kind of go to these crude cook stoves that have been of interest in research for the past several decades, and think about women and children who are exposed to these very, very, very high levels of particulate matter and pollutants relating to cooking and kind of surviving. And certainly that is definitely the case, where there have been numerous studies looking at cook stove exchanges and how that improves PM and health outcomes. And I think the question is kind of, can we take this paradigm of indoor air pollution and place it in our own society, where we're not necessarily cooking over crude cook stoves, but we are cooking in our homes? And what do we know about indoor environments in people who are exposed to a lower pollutant burden? And that's been an interest of mine and the research team that I work with. And this is just showing that, you know, within a house, there are many sources of pollutants from outside: mold, bacteria, pets, off-gassing from your car, radon coming through their basement, all sorts of things that we can be exposed to in our homes. One thing in particular is nitrogen dioxide, which is also regulated in the outdoor air, but importantly has indoor sources that are right in our homes, including gas cooking appliances, furnaces, and space heaters. And because of these indoor sources, the majority of what we're being exposed to in terms of NO2 on a daily basis is what's inside our home and not necessarily the outdoor sources. We do have limits on the outdoor environment, but as I mentioned, no real indoor limits. As a fellow, I did a lot of work on gas stoves in particular, and especially in urban areas and poorer areas, kind of gas stove use is very common in row homes in Baltimore, and oftentimes families are using stoves for primary fuel heat because the gas line for the stove isn't turned off, but if you don't have enough money to pay your utilities, your gas line for the heat is turned off. So people often open their stove for warmth in the winter time. So it was a particularly pertinent pollutant to study in Baltimore City. In terms of COPD, we did do a study looking at indoor air in homes of former smokers with COPD in Baltimore City. And the main reason I put this up here is just to show you the sampling equipment that we used at the time. This was just in a recycling bin, and you can see that there's kind of a bunch of tubes and wires. The black and gold circles that you see are impactors that basically, and then the tubes are connected to pumps that suck air in at a known flow, and basically air goes through those impactors and preferentially deposits on the filters. Depending on the size of the holes in the airflow, you can capture PM10 or PM2.5 or whatever size fraction you're looking for. The thing that's taped on the orange tape that says HOBO, that's a temperature and humidity sensor. The thing peeking out top with the gray top is a kind of a real-time PM monitor that has a light scatter laser that is capturing concentration over real time. And there's an NO2 badge, a passive badge in there somewhere. And all these things we put in people's homes on a regular basis and kind of monitor the air. repeat this measurement over the course of the entire study. This one went in the house for a week at a time. And the study that we looked at that point had 84 people in it, and basically most people spent most of their time indoors in their own home. And the takeaway from this one, this is kind of a busy slide, but just to summarize, increases in PM were associated with more wheeze, more nocturnal symptoms, more use of the inhaler, and a worse quality of life. The SGRQ is the St. George's Respiratory Questionnaire, and higher amounts of NO2 were associated with increased dyspnea and increased inhaler use. And this was in homes that had relatively low concentration, so nothing like what we're seeing in developing countries of women cooking over these very crude cook stoves. These were kind of East Coast American homes with not open fires in their homes. So the concentrations were quite low, and we were still seeing an association with higher PM and NO2 and meaningful health outcomes in this population of people with COPD. So, what can we learn more about in terms of what people's exposures are? There's always been an interest in, especially when we're talking about kind of heating and cooking. We know that people across the United States are using solid fuels for heat in their homes. And we know that the indoor sources of these rural homes are important. We also know that in general, we're really not capturing even the outdoor exposures that are happening in rural areas. And as I mentioned before, when we looked at those trends of the Clean Air Act, that was based on kind of nationally available EPA monitors that are looking at trends over time. If you look at this map, this is active EPA monitors for PM 2.5. And you can see that there's this huge swath in northern New Hampshire and Vermont that really is not being represented by any EPA monitors. So, who's to say that, if you're in Colebrook, that your pollution is the same as what you're seeing further south or even here, and we just don't know what trends are happening there. Certainly, we don't expect there to be some huge factory that we don't know anything about up there, but we really don't know what the trends are based on airflow patterns and kind of local sources and what that may do to local PM concentrations. When we talk about air pollution, we kind of talk about it in these big swaths and like making generalizations about an area, but we do know that air pollution varies very heavily by time and space. So even block by block, you can get very different concentrations of PM or any of these pollutants, and we're really failing to capture that in a rural environment. And like I said, many of these homes are using wood and coal for their primary source of heat, and even more are using it for secondary heat. This was a pilot study that I did in rural Appalachia in Lee County, Virginia, which is the southwesternmost county in Virginia that borders with Kentucky and Tennessee. And we did a study there, a pilot study, where we just observed homes and looked at kind of fuel use by different homes. It was a small pilot study, but we found a very high concentration of PM in the homes using solid fuels, less so than gas, and then kind of less from electric. So again, this suggests that higher concentrations in homes using these solid fuels. And when we know about what people do in the homes, there is some interesting data that it's not only what you're breathing when you decide to use solid fuels in your homes, it's not just impacting you, but it's also has a potential to impact your small community. One of the things that can happen here in certain areas with certain geography is that you can get an inversion layer where basically pollution from wood smoke and cars can be trapped by this cooler layer of inversion. And this happens here. This is a picture from Keene, where one of my collaborators is at Keene State, Nora Travis. She has shared this picture that shows kind of these homes on the valley that are using wood smoke, and you can see some chimneys there with smoke coming up, and all of that wood smoke is trapped by this inversion layer, and this has led to high concentrations of PM in Keene, and to the point where they were out of compliance with the Clean Air Act several years ago. And we've seen that before. in other parts of the country. This was Libby, Montana, which is this tiny town in northwest Montana, and they were out of compliance of the Clean Air Act. And people were, what the heck is going on in Libby, Montana? And they found that it was cold and people were burning their wood stoves, and there's an inversion layer there, and they were getting these super high concentrations of PM in the local community. Researchers there did a study and found that if they were able to switch out the stove to be more efficient, they actually decreased PM concentrations both in the house and outdoors. So this suggests that kind of individual behaviors are really contributing to community levels of pollution. So what does that mean for us here at Dartmouth? There are several different studies that are kind of in progress right now looking at air pollution. Most of them focused on PM, but also some opportunities to look at other pollutants. In the New Hampshire birth cohort study, there is currently, well, things are on hold for now, but there is prenatal monitoring of PM and NO2 in the homes of pregnant women in the 3rd trimester, which is thought to be a susceptible period for fetal pulmonary development, and also looking at personal air monitoring at 3 years old, where children wear a little backpack with air monitor in that. And these provide the opportunity to look at the association between these exposures, both in utero and as a child, on childhood health outcomes of infections, respiratory disease, inflammatory biomarkers, and eventually lung function. There's a whole host of other outcomes within the birth cohort study that will allow us to explore these exposures and health outcomes in kids. So that's exciting. That's current work that we're working on now. And we're also thinking about adding data on ultrafine particles. If you remember that slide with PM, the smallest particles can get all the way down to the alveoli, and they can essentially participate in gas exchange and get incorporated into the systemic circulation, cause a whole host of inflammatory outcomes. And oftentimes that's what people are thinking are implicated in, increased strokes and increased cardiovascular deaths related to air pollution, and maybe because of this inflammatory response. We have several of these monitors that are able to capture ultrafine particles. Prior to the last 10 years, I would say, these were huge machines that required a great deal of airflow to get enough flow to capture these tiny, tiny particles. But recently now they're using this light scatter method, and they're much smaller, but also very expensive. This monitor here costs about $10,000, but it does afford us a great opportunity to look at the concentration of these smaller particles on a real-time basis. And this graph here is showing these peaks that you can see over a period of minutes related to different cooking events in someone's house. And these are kind of normal cooking events, nothing crazy, but we can see a lot of variability even within one home. So we're really looking forward to seeing that within person variability and between home variability moving forward. So future work, we're lucky to have several different potential studies going on to get a better sense of kind of indoor fuel use in our area right now. We have a group here that includes the woman from Keene, Nora Travis, and also Brian Jackson, to look at compositional analysis of PM, to see if we can figure out kind of, do different solid fuels have a different type of signature that could be used to kind of track different fuel types. So looking at different metal components and organic components to see if those are implicated in health outcomes. And we are hoping to be funded by the Irving Institute for the SEED grant program. We've made it to kind of the final round, and I believe that this funding is going to come through. So we're very thankful to the Irving to support this type of work to further characterize these solid fuel types in PM. I myself have a grant going in for resubmission to build a cohort of individuals with COPD from this area, to follow them in their homes and to look at trends in air pollution over time and pair those with clinical outcomes. And all of this is very important to, in terms of involving the community and kind of empowering the community, that these this citizen science type of work is really important in getting a sense of what is happening around the area. Given that we have fewer kind of national and statewide monitors, can we inform people and empower them to kind of look at air pollution on their own terms? And there's some low-cost sensors that allow this to happen. Purple Air is one of them, and you can actually use these monitors with real-time feedback wirelessly, and they can connect to a network of neighborhood monitors to see what's happening in your neighborhood and across the state. So we're really excited about that too. And all this is important because eventually we want to be able to kind of guide people on how to decrease these exposures. And I could spend a whole talk on interventions, but I'm not going to. I'll just say two things. We can do smart wood burning, and that can decrease indoor exposures. And there are many, many steps and tips by the EPA on their BurnWise website. And then we can think about what we can do about the actual, not only the fuel source, but kind of what can we do about the air in the house. And one of the studies I'm working on is looking at HEPA air filters and carbon filters to decrease indoor PM and NO2, and look to see if that improves COPD outcomes over time. So in summary, we know that these historical events have helped us determine that there is a causal relationship between air pollution exposure and multiple health outcomes in the United States and people with and without existing disease, and that indoor air is important too, and rural air is also very important. So I will stop there. And,
Laura, that was absolutely super. I mean, one of the things that we really appreciated when you came and spoke to my energy and environment class this last winter was how so many of the students didn't realize air quality was a problem. And your lecture made them almost fall off their chairs. And I remember it was one of the ones where they're like, how can we protect ourselves? How do we protect our families? And it was just something they had thought was solved. They thought that air pollution was something that had been cured. And some of our questions are also really interested in indoor and outdoor air quality differing. And you talked about that, but also the indoor air pollution, the role of HEPA filters, the volume and makeup of air. And please feel free to submit your questions as you go forward. And I'm just wondering if you have any observations of indoor air quality in the current crisis, as well as your
Oh, I didn't even mean to do that, but that was
perfect.
I know, I really didn't even mean to do that, but I did put this slide in here because I thought that people would ask about SARS-CoV-2, and we don't know a ton about it yet. I think that there's some discussion that there's two things going on. Some people think that air pollution trends might decrease over time since mobile sources have decreased, but we haven't really seen that. And then the other thing is, you know, are people more susceptible, people exposed to higher amounts of air pollution, are they more susceptible to the health effects of SARS? And one paper kind of came out of Harvard that was pretty provocative, that suggested that people living in areas with higher PM 2.5 concentrations had a higher risk of death from COVID-19. And so there was some suggestion that this might be the case, but we really don't know that much about it. I would say that there are a lot of people interested in this, and I have a phone call tomorrow that's looking at PM exposure and ACE expression in a basic science model, and we're trying to figure out if this is worth exploring in larger cohorts.
There was one question here on what is the impact on local air quality in the Upper Valley and our health from Dartmouth burning number 6 bunker oil and Dartmouth Hitchcock?
Yeah, so that's a really good question, and to be honest, I don't really know. I do think that there are data out there about kind of air monitoring, but I haven't seen them, and I'm not quite sure if they're publicly available or if they're kind of done on a more of a need to know basis. But I think that that's a really great issue, and I know that there's been a lot of discussion about that, and kind of what our alternatives might be, and you know, do we do we wait until we have the perfect energy solution, or do we change things now knowing that our current setup may be less than ideal? And I don't have great answers about that, but there are definitely people who are kind of working on this for sure.
Here's a question from Kali Smolin. Do any of your studies combine the effects of air pollution and climate change?
Yeah, so I don't have slides here, but I have a couple studies I've worked on have looked at temperature extremes, which is, you know, obviously a component of climate change, but we were able to look at this population, a local cohort of people with COPD in Baltimore City, and looked at extreme heat and found that even when accounting for these air pollution exposures, being exposed to extreme heat was associated with increased symptoms and increased exacerbations in a local cohort. And that was for people who are even spending times indoors. So that had some implications in terms of kind of ideal housing in terms of air conditioning, access to air conditioning, but there was some suggestion that these higher extreme temperatures were associated with worse outcomes. But there is a lot of activity around climate change and pulmonary outcomes and air pollution. And there's a researcher at Harvard, Mary Rice, who has a similar background to me, and she's very active in this area. So I encourage you to look her up. She's very active in climate change and kind of lobbying through the American Thoracic Society, which is our professional society, to hopefully make a change for improvement.
We have a question from Thomas Barak, who was our Rocky Fellow this last year and was with IES as well, and has worked a lot with the state of New Hampshire. And he says these two pollutants may be outside of Dr. Paulin's areas of study, but it would be interesting to know if she has any thoughts on indoor radon contribution to lung cancer and the impacts of elevated CO2 in indoor air.
Yeah, that's a great question, and I don't have as much experience with that, to be honest with you. I do know that radon is typically more regulated just from a commercial real estate standpoint. So, you know, there is some suggestion that over time, long-term exposure to radon can be associated with lung cancer, and especially there might be some interaction with smoking. I don't know a ton about that to be able to comment on it more, but it's more of a kind of a long-term indolent exposure and not necessarily these short-term exposures and outcomes that we tend to see with the other pollutants. And in terms of CO2, that typically historically had been an issue with a lot of kind of big, dirty factories and mobile sources, and those trends have decreased over time, but I don't know as much about CO2 in the indoor environment.
Could you mentioned it briefly in your talk, but there was a question here about how biomass combustion impacts air quality, and I think they meant indoor and outdoor air quality.
Again, in terms of, you know, most of the work that I've done has been kind of local indoor use of solid fuels, and that certainly can lead to these indoor air concentrations that are high, and also community levels that are high. But in terms of kind of biomass on a larger scale, you know, in terms of like looking at biodiesel and those other types of fuels, there's been a lot of interest in that as well. And I don't know the data as well more recently, but in the past there was kind of pros and cons to the renewable energy side of things, but also a higher concentration of PM potentially.
Here's one more. Sorry. So one of the questions asked about at what concentration does carbon dioxide start to cause human behavior changes, and then how indoor and outdoor air quality differ?
I don't know that much about, I don't think I'd be able to comment on the outdoor concentration of carbon dioxide. certainly we know about it from like a medical standpoint more, but I wouldn't be able to relate that necessarily to air pollution.
Mm-hmm.
And then the indoor and outdoor, so it's not necessarily, we can tell a little bit more if you actually look at the composition of PM, whether or not we think it came from indoor or outdoor. But there's no magic switch that happens between the indoor ones and the outdoor ones. It's still, you know, a lot of the same studies have shown a support between PM of indoor source versus outdoor source and these health outcomes. But we can, if you care to, there are ways to kind of look at the actual makeup of the PM to decide whether or not it's coming from outdoor or indoor or what the sources might be.
No, and I know that people think about these issues quite a bit, and I really appreciated your slide linking to COVID. What would be one last thought you wanted to leave the audience with before we moved on to talking about our next ongoing programming? When it comes to thinking about the impacts of air quality.
I think it'd be important to know that, you know, we do have somewhat of a control over what we do in our homes. And so just making sure that we're up to date on all the recommendations. If we do use solid fuels in our homes, making sure that we're doing it as safe as possible. And then knowing that, you know, air pollution, like outdoor air pollution is, you can't hide from it. It affects all of us. And certainly there are areas of cities in the country that are more disproportionately affected by air pollution, and those tend to be poor, more disadvantaged areas. But overall, we all are exposed. We all breathe air. So anything that you can do, if you hear of any policy or legislation that could help improve air quality, then definitely get your voice out there, because, you know, we're all impacted by this.
Thank you very much. There's some extra questions that we'll be able to pass on to you, Laura, and you can contact the questioners directly. And Laura, thank you so much for your contributions and for really letting us all think more critically about the air that we all breathe and all depend on. So thank you, everybody.
Thank you so much
Virtual
for having
claps. Me. Yeah. Okay, take care, everybody. Have a hopefully sane week. Bye-bye.